Hi, everyone. Good morning. Thank you so much for coming. My name is Ryan Gise. I am one of the pediatric ophthalmologists and neuro-ophthalmologists at Boston Children's in Boston, Massachusetts. I am an assistant professor of ophthalmology. It's one of my absolute favorite topics, so I'm excited to share it with all of you and answer some questions afterwards. My goal is to make it really, really clinical. So I have no disclosures. The goals of the talk are to really be able to determine and interpret which OCT is most useful in each situation, how we can get them done in children, how we use them to localize and time when a lesion happened or when an incident happened, and how it can help us guide management decisions if we notice that vision is declining in some of our patients, and kind of for next steps for our colleagues in neurosurgery, neuro-oncology, and neurology, among others. So what is optical coherence tomography? It's an in vivo, so in real life, non-invasive imaging modality of the retina and optic nerve fibers, which are surrogates for afferent visual function. The theory is that an insult to the visual pathway may lead to damage of the axons of the retinal ganglion cell and then cause thinning by Wallerian degeneration if it's in the anterior visual pathway, or retrograde transsynaptic degeneration if the posterior visual pathway is affected. So basically, anywhere from the very front to the very back, we can see changes in the OCT and the different types of OCTs that we can use. We're trying to figure out where everything is, because that's why people come to pediatric neuro-ophthalmology, is to figure out where things are, why things are happening, and then how can we help make things better. So I think this is one of the biggest questions that everyone always asks, is that how do you get an OCT in children? And the answer is we have a couple of different types. So there are now handheld OCT machines with varying levels of utility. The pictures. This is from the Pediatric Retinal OCT and Eye-Brain Connection textbook out of Duke. But basically, they demonstrate how you can use the handheld OCT, which we don't have yet in my practice and is not widely used, but can be used to help look at structure more than anything else. So it doesn't have the same printouts that you have from the more stationary machines. And then you have a picture of a young kiddo getting a OCT performed on him. And this is he's probably about 3 or 4. That's about the youngest that I've found that we can get reliable OCTs on, and it's kind of hit or miss depending on the kiddo. I always like to point out that OCT macula scans are the fastest scans, so they generally help in that sense because they just go the quickest. And then you can see a lot of utility in the ganglion cell layer, which we'll talk about in depth. And this was the Heidelberg Spectralis OCT machine. I know there are a lot of them. That's pretty much the major machine that I'm going to be talking about today, as it's what we use here. So how does OCT help us? Well, it's the what, when, why, and where of the issue. So where is the problem? How do we find the lesion? When did it happen? In our kids who are not always subjectively easy to get great data from, can it be a surrogate marker for vision? I have a patient who has an optic pathway glioma who's now 4, and I've been seeing the patient for 3 years. And the patient is now wonderful at doing OCT ganglion cell layers. The patient is not that great at doing visual acuities, depending on the time of day and her mood. So it is very helpful because it gives us an objective piece of data that's reproducible. And then monitoring, again, an objective measure. So what types are particularly good in kids? So the types that I predominantly use are OCT nerve fiber layer, retinal nerve fiber layer, RNFL. We do sometimes use optic nerve head volume or EDI-OCT. So optic nerve head volume can be used to really quantify the 3-dimensional volume of the nerve, but it takes a little bit of maneuvering and tech time or physician time to actually move the different layers around so that you actually measure the optic nerve swelling. So it's not as easy as a retinal nerve fiber layer, which the computer has an automated algorithm that kind of spits out. And then enhanced depth imaging OCT is very useful for looking for optic nerve head drusen. And then in the macula, there's obviously the OCT macula, and then the ganglion cell layer, which I think of as the Swiss Army knife of neuro-ophthalmology, and is helpful, or afferent neuro-ophthalmology, I should say. So why doesn't everyone just get OCTs on kids, and why are there concerns, and what are the problems? Well, the major one that people talk about is that there's no normative values for children younger than 18. And this is true, although there are a lot of different studies that have demonstrated what some normative data could look like. You just have to know numbers versus actually looking at the colors on the printout that you see. There are no normative adjustments for high myopes, and I would argue that they should have put high hyperopes on here too, as a lot of the children that we see can be highly hyperopic, especially when there's a question of papilledema versus pseudopapilledema. And so that can be an issue, and definitely spherical equivalent can definitely affect OCT readings. Again, pseudopapilledema or thickened nerves in the setting of high farsightedness or just anatomically different nerves. Optic disc drusen, which we'll look at a little bit in depth more coming up, that can throw off your numbers. Other disorders of the optic nerve head, myelinated nerve fiber layers, gliosis if the nerves have been swollen before. All of these things can kind of break up your interpretation and make it a little bit more fuzzy and a little less cut and dry in terms of what the numbers are. And then, it's one of those things whenever I discharge a patient, especially one who had optic nerve swelling in the past or papilledema in the past, I always tell them that, when you see the next doctor, they may think your nerves look a little different, and that's okay. And I try to give them a copy of the photographs that I take, because gliotic nerves usually stay gliotic forever. Segmentation failures. So if an RNFL is over 200, usually most of the algorithms stop working. The proprietary ones especially. There are some research ones that are better that I don't think have been put into proprietary use yet. I've noticed that and I have no financial interest in any of this, but I've noticed that the Spectralis from Heidelberg tends to be a little bit better with segmentation failure than the Zeiss Cirrus, especially with the ganglion cell layer. And then artifacts. So if low signal strength, if a kid is looking around, high refractive error, cyclotorsion, all of these things can cause us problems, but that doesn't mean that the tests aren't still very useful. So what do I use them for? So when I think about retinal nerve fiber layer, I think about structure and function. That's kind of the question that I ask myself whenever I am looking at OCTs. Is this a structure issue that I'm looking at right now, or is it a function issue? So for retinal nerve fiber layer, the structure piece is the nerve swollen? Is the RNFL higher than what I would expect? Am I worried that there's something going on, inflammatory, high pressure, et cetera? Then if the nerve is atrophic, then it becomes a question of function, because atrophic nerves don't usually swell, although they can, which is not the common teaching, but is what's been borne out in practice. But basically, so is the function working? And so if it's atrophic, obviously, then there's been damage to function. And then optic nerve head volume, like I talked about a little bit before, is the nerve swollen? Is the RNFL greater than 200? If the RNFL is greater than 200, then an optic nerve head volume will probably give you a more accurate reading, because it's a technician or a physician actually segmenting each picture so that you have an accurate 3-dimensional millimeters cubed volume of the optic nerve. Not a lot of people use this in practice. I find that it slows my flow of my clinic down significantly. And if an RNFL is greater than 200, usually, as one of my mentors would say, you can look in and just see that it's really swollen, and then it will get better. And then for volume is like an enhanced depth of imaging scan. It just is a few less cuts, but still can identify optic nerve head drusen, although the cuts are, an EDI scan is like looking at high definition, and an optic nerve head volume is like looking in standard definition. And then OCT macula, so a ganglion cell layer. So ganglion cell layer on the Spectralis is an actual 3-dimensional volume of that layer. So the numbers are different from the Cirrus, which is the ganglion cell complex. So by that, I mean the ganglion cell complex includes the interplexiform layer, which gives it a floor effect, because the interplexiform layer doesn't thin when you have optic atrophy. Whereas when you use the Spectralis and you use a full ganglion cell layer, it could technically thin to 0. And I've seen it thin as low as 0.15 millimeters cubed after a retinal artery occlusion. So OCT for the ganglion cell layer, you're really looking at function. Is the nerve, is the visual system atrophic? Has there been damage? And then in terms of the OCT macula, I'm looking for subretinal fluid, inflammation in the vitreous, again, structure. So these are your two questions. Are you looking for structure? Are you looking for function? I really like the OCT macula because one scan can give you both of these. And I really like the RNFL because, again, one scan can give you both of these, but an RNFL definitely takes a lot longer in relative terms. So going back to the question of, is there normative data? And the fact that there isn't, but there have been a couple of studies. This one by Jenna Haidari and Linda Doggy was presented at APOS in 2015, where they basically took a normal cohort of children who had spherical equivalents between -4 and +4 and put them through macular volume, optic nerve head volume, and global RNFL thicknesses. And if you look at the third column over here, it looks basically like around 100 is a pretty normal global RNFL thickness. If you look at the new prospective pseudotumor trial in children that's starting, the PPTS led by CHOP, their criteria for inclusion actually requires RNFLs to be over 130. So I use 100 to 120 as my usually pretty good zone, and 120 to 130 as my gray zone, and then 130 plus is not always a swollen nerve, but it does make me a little bit more concerned. So it's just ways that I kind of can help. And then we'll also look at cases where you can't just look at numbers. For ganglion cells, so as I said, it's a millimeters cubed volume. So normal is 1 millimeter cubed to 1.2 millimeters cubed. And you can definitely have ranges in there, and it also varies with spherical equivalent. That's what the chart above says. As you can see that all of the scans tend to vary a little bit with spherical equivalent, although the slope of the line is much lower in the optic nerve head volume, so it's not quite as effective. And then we get this great picture in this great textbook. So Grant Liu, Nick Volpe, Steve Galetta, Scions in Neuro-Ophthalmology wrote this wonderful textbook. I highly recommend it. I think everyone should read it. I think it's really fun to read. I think that it's well written, and it talks a lot about all the various things that we see in neuro-ophthalmology and provides a great foundation for that. And so in this picture, you see the visual pathway. And so the goal is to show you how your OCT RNFL can take you from the front of the eye all the way to the occipital lobe before you can't see any changes on OCT. So typically lesions in the occipital lobe, which don't tend to cause optic atrophy, which don't tend to cause afferent pupillary defects, also don't tend to cause changes in your ganglion cell layer. So that's kind of where the limitation can be in terms of use of OCT, is that once you get into the very end of the visual pathway, it stops projecting forward. And so you just have to be very mindful of that. And then just like with visual fields, depending on where the lesion is, you can have different visual field defects. So if it's in front of the optic chiasm, it's usually a one-eyed problem. And then if it starts at the chiasm and behind, it starts becoming a two-eyed problem, meaning that you see changes in both eyes, not just changes in one eye. And so again, that helps you localize a lesion, and we'll see how that also holds true on the OCT imaging itself. So let's start with some cases, because it's enough of me talking. So a 5-year-old boy who presents for evaluation in the setting of a clinically isolated syndrome. So what does that mean? He developed right leg weakness about 2 months prior to his presentation and was hospitalized after progression to right hemiplegia. He was found to have multiple lesions on his MRI concerning for multiple sclerosis. One of the problems with the McDonald's criteria is that it does not hold up very well, especially in young children. So our neurology team was looking for more information. A follow-up MRI 3 months after symptoms started revealed new lesions, and he was diagnosed with multiple sclerosis. When I saw him for his baseline exam, he had normal afferent visual function. His optic nerve looked perfect. He looked like a normal 5-year-old boy. When you do his OCT RNFL, you actually start to see that he has thinning of both optic nerves, which is consistent with a diagnosis of multiple sclerosis. So if you look at this meta-analysis by Dr. Petzold, where they looked at 40 articles that examined multiple sclerosis related to optic neuritis and non-optic neuritis eyes, they actually found that obviously the optic neuritis eyes had the thinnest RNFL and the thinnest ganglion cell layer, but patients with MS who did not have clinical events of optic neuritis had thinner layers in both segments as well. So it's just another kind of marker of disease activity, another way that we can help our colleagues in neurology. So another case. So this was an 18-year-old woman who presented with right-sided acute vision loss. It started with a frontal headache and evolved into progressively worsening vision. It's really important to, when you're dealing with children, and I know she's 18, so she's an adult, but when you're dealing with children, a lot of times when they have pain with eye movements, they'll actually report a headache because they can't distinguish between the two. And also, it's really important to note that pain with eye movements is much less common in children than it is in adults, where it's about 90% of adults with optic neuritis will have pain with eye movements. It's more like 50-50 in kids where they have pain with eye movements, or if they're not able to describe it. Over the course of the first 6 days of illness, it dramatically worsened to a large central scotoma and decreased vision to 2400. Imaging revealed right optic neuritis with other lesions in her brain concerning for multiple sclerosis. So how does OCT help us? So on her initial presentation, she actually, it looks like, had a mildly swollen nerve. Her right optic nerve was around 120 in terms of a global RNFL. Her left optic nerve was 113. So you can see this kind of asymmetry. But about a month later, the two nerves were very symmetric. And you can see on the red-free image even that it does look like there was a little optic disc edema. And so another thing is that in adult patients, typically optic nerves don't swell, whereas in pediatric patients, it's actually more common for optic nerves to be a little bit swollen. And again, this patient is kind of straddling pediatric and adult. But the RNFL right here gives you a lot of structure. The nerve was a little bit swollen, now it's not swollen, but this doesn't tell me anything about how her vision is and how her optic nerve is functioning. And it's already been a month. If you look at her clinical course, her visual acuity didn't really change after she was pulsed with steroids. So then we look at the ganglion cell layer. And when we look at the ganglion cell layer, and I know these pictures are really small, but what I want you to focus on is how dense the yellow tissue is, because this is that ganglion cell layer. And over the course of the first 2 weeks, you can see that the yellow is starting to become much less dense. And then over a month, the yellow has become a lot less dense. So ganglion cell layer, and this is my first pearl, tends to thin starting around 2 weeks after an insult, whereas RNFL tends to thin around 2 to 3 months after an insult. So ganglion cell layer can tell you what's going on faster. There are also many studies, especially in multiple sclerosis patients, that have shown that ganglion cell layer or ganglion cell complex values are highly correlated to patients' disease severity scores and visual function scores and low contrast visual acuity. So all the things that are most highly affected in multiple sclerosis. And you notice that she went from about 1.13 to about 0.88 over the course of a month. So she thinned by roughly 20-ish% over a month, whereas her other eye stayed totally normal. And so if we go back to our visual fields, this is a one-eyed problem. So we know we could have localized it to the optic nerve already, and it would pop up there just like on a visual field. So her final diagnosis was optic neuritis secondary to multiple sclerosis. Case 3. So this is a 14-year-old thin boy with poorly controlled Crohn's disease who presented for evaluation in the setting of headaches and possible papilledema. He reported that he started to have headaches 2 months prior to his presentation after a recent steroid course. He'd been on and off steroids for the Crohn's disease. He had 1 to 2 headaches per week with occasional nighttime awakening, so that's a red flag sign. No light sensitivity or sound sensitivity to suggest migraine, some nausea, and the symptoms are worse when lying down. So again, red flag sign. High pressure headaches typically are worse when you're lying down than when you're standing up. No transient visual obscurations, no pulsatile tinnitus or diplopia. So in kids, I don't always say, do you have transient visual obscurations? Because that's not what they know. I say, when you bend over and stand up, does the world ever go black for a split second? And then you have to tell them, make sure that it's not the same thing as orthostatic changes too. Like, it's not when you get dizzy, or not when you get woozy, or not when the world goes blurry, does it go black? And then the other thing that I ask about with pulsatile tinnitus, do you hear a washing machine in your ear, or a heartbeat? Because that they know more than pulsatile tinnitus. And it's important to distinguish it from ringing, which pulsatile tinnitus isn't. So he was then sent to the ED and had an MRI MRV that was noted to be normal, and then it was referred to me. His afferent visual function was normal. His Humphrey visual field was totally normal. His efferent visual function was totally normal. And his anterior segment exam was, surprisingly, totally normal. Here are his fundus photos. So on the top images, it's more more kind of further away, and then blown up on the bottom. You can see that there's nasal fullness, maybe some temporal fullness as well on this side. So probably I would call it Frisson grade 2 if it was related to high pressure. That's the important thing to note. Whenever you use Frisson grade, it's specifically designed to describe papilledema or papilledematous nerves. So if you have optic disc edema from optic neuritis, then you could say Frisson-like, or the easiest thing to do is just describe what you see. So I see a nerve that has 360-degree margin blurring, maybe a hint of a lumpy, bumpy appearance here. And on the other side, about 270 degrees of margin blurring with no vessel obscuration on either side. So then we got our OCT. And remember, another pearl, always throw out the colors when you're looking at it. If you are using a glaucoma set device, everything will be green unless it's atrophic. So a number of 161 will actually still be green. So I always try to ignore the colors. The colors don't always matter. And sometimes they lead you down the wrong path. So his right optic nerve, even though it looks kind of swollen, the RNFL is actually pretty normal. The left RNFL is much higher, even though it looks pretty normal. So then I look at his ganglion cell and layer, and since he had excellent visual fields and excellent vision, I would pretty much assume that this would be normal, and it is. You really can't be too high in terms of the ganglion cell layer. So 1.33 is considered normal. The only time where it becomes pathologic is if you have some kind of intraretinal ischemia and edema on the intraretinal layers, like a CRAO, or kind of acute areas of ischemia if you have too many white blood cells from CML or other kinds of leukemia and have some focal ischemia, that can become too thick, but that's much, much thicker than this. And then we do an EDI-OCT. And we find these two findings. So one with the red arrow and one with the orange arrow. And so I'm going to ask you guys, what structure is indicated by the red arrow on the previous slide? And you'll see it again in the picture in a second. So the red arrow, is it optic disc drusen, a blood vessel, choroidal neovascularization, or a peripapillary hyperreflective ovoid mass-like structure, commonly called PHOMS? All right, so perfect. So kind of a split audience in terms of what we see. But most people think it's a PHOMS, and you guys would be correct. It is a PHOMS, and optic disc drusen is on this picture, but let's go back to it for a second. So the red arrow is pointing over here, which is a PHOMS, and the orange arrow is pointing over here in both, and these are hyporeflective cores with hyperreflective borders, which are indicative of those calcifications. And we'll talk about them a little bit more. So what is a PHOM? So until about 2018, it was thought that PHOMS were drusen precursors, but that's been disproven. They are peripapillary, hyperreflective, ovoid, mass-like structures. So their name describes exactly what they are. Peripapillary, they're around the optic nerve. You can see them in the red circles here. So they're kind of like a donut, or toroidal is another word that people use for it, around the optic nerve. They're thought to represent axoplasmic stasis. And they are hyperreflective, not hyporeflective, like I was talking about with drusen. So if you look at the yellow circle here, this druse, this calcification has a hyperreflective border and a hyporeflective core. whereas the PHOMS is hyperreflective and dense, and then it's mass-like, meaning it pushes up at least 2 layers of the retina. And so when we look at those pictures, the blue demonstrates the PHOMS, and the red demonstrates the optic nerve head drusen from the picture before. And so we've looked at these, and the question is, and I think the question that everyone's wondering is, what do we make of these? Are they pathologic? How do I interpret if there is a PHOM or not? And the answer is that you can have PHOMs in patients with normal optic nerves. Usually they tend to be myopic. So 1 out of 4 Danish children with myopia were found to have them. They're obviously more consistent and more present in those with optic disc tilt or longer axial lengths. We looked at our children at Boston Children's with optic neuritis, papillitis, drusen, papilledema, and neuroretinitis. And we found that it was most common in patients with papilledema and drusen. Drusen is had PHOMS. So you can't just say, oh, there's a PHOMS, there must be something wrong. You can see it in pseudopapilledema. You can also see it in other ocular and neurologic conditions. So they're kind of a marker that something could be going on, but not necessarily something that's dangerous. So then we kept looking because we're trying to find a reason why we need to be concerned with PHOMS or have PHOMS. And in some special populations, they can be helpful. So this was a study that we did looking at patients with craniosynostosis. And these patients with craniosynostosis, those who had PHOMS had a much higher odds ratio of having had increased intracranial pressure in the past or having it currently. So patients with craniosynostosis, if they have PHOMS, then I would be much more concerned that they have increased intracranial pressure because they as a population tend to have more increased intracranial pressure. And then the question that I think everyone asks is, how do we best identify optic nerve head drusen? And so here on this slide, you can see 2 nerves that, again, frizzen grade 1 to 2, like edema, or if it's papilledema, grade 1 to 2 on both sides, no real vessel obscuration. And then in this study, which was done in the early 2010s, they were using ultrasound, and they saw very hyperechoic ultrasound findings. And ultrasound is a very useful tool. I just think OCT has become a little bit more useful. But in this study, which I think is really important, especially since there's people all over the world on this call and this webinar, what they looked at was patients who were seen by ophthalmology who got an ultrasound first or got an MRI first. And in the United States, we obviously have a problem with the cost of healthcare. And in terms of actual dollars, it was about 4 times more expensive for the patient if they didn't have an ultrasound prior to having an MRI. And these are all patients who didn't really have any symptoms or minimal symptoms. There was not a ton of concern overall for like a clear brain tumor or other CNS process. But you see that it was much cheaper for patients to have the ultrasound first. And then I would also add, and this is something that's harder to quantify, but was probably also a lot better for the patients. They didn't have to go to the emergency room and wait for hours to get an emergent MRI. They didn't have to, have the anxiety of thinking that their child might have a brain tumor while they were waiting for the neuroimaging, because they had an answer that this was likely something else. And I think it's really hard to quantify that, but I would argue that that is probably one of the most important pieces of what we do is also managing kind of sick patients and non-sick patients, and making sure that we set expectations and kind of work with families so that the anxiety of these health problems in their children don't take over their lives. And more recently, so Dr. Bertstein published this study looking at EDI-OCT versus ultrasound versus fundus photography versus autofluorescence. And again, you can see an optic nerve head drusen down here. And basically what they found was the most accurate in terms of specificity, sensitivity, accuracy, precision, examiner confidence was EDI-OCT. because you can really see what these drusen look like. And it's not always perfect. And sometimes you kind of think, well, maybe it's a hint of drusen, maybe it's not, and you get more comfortable as you read. But you can see, I would be very hesitant in calling this optic nerve head drusen on the ultrasound versus calling it on the EDI-OCT. I would feel much more confident. So I just think they can be a little bit easier to interpret. And it obviously depends also on what machines you have. So if I didn't have a machine that could do EDI-OCT, I would do the other tests. I think they're all good and they all serve purpose, and they're very helpful. So next steps for our patient. So he was having headaches. He was having some concerning signs or symptoms. He actually went ahead and had a lumbar puncture. His opening pressure was 28, which is borderline in a child with normal body habitus under sedation. But we decided that we would start him on topiramate because he has possibly chronic headaches, maybe some mildly elevated intracranial pressure. This should take care of both of those issues. And 4 months later, you can now see that the nerve borders are much sharper in both eyes, and you can start to see some of these bumps that we were noticing were drusen. And so he actually ended up having both. And you can see that even his normal RNFL of 107 went down to 89. So his actual RNFL is about 89. And the other eye went from 161 to 107. So there was a component of increased intracranial pressure, and it's something that we see not infrequently in patients who have pulses of steroids. So patients who have leukemia, we wrote a paper in the Journal of Neuro-Ophthalmology looking at our neuroophthalmic manifestations of childhood leukemia, and one of the most common is increased intracranial pressure from either infection, leukemia itself at diagnosis, or the chronic steroid use and coming on and off of steroids. So that was his final diagnosis. So case 4, a 14-year-old obese girl with recent significant weight gain and increasing headaches over the 4 weeks prior to presentation. She reported pulsatile tinnitus and transient visual obscurations, but denied diplopia. She had no new medications like antibiotics or acne medications. Her afferent visual function was essentially normal. Here were her optic nerves. These are the most swollen optic nerves I have ever seen. They were so swollen that this is an optic nerve head volume. So you can see that you segment the top layer to be around the nerve, and then the ILM, the bottom layer under here, and it has to be manually segmented. Normal is around 3. Hers was around 11, but 11 plus because part of it was cut off. And you can see that she actually had subretinal fluid spilling over from her very swollen optic nerves. Here were her visual fields, and I always like to point this out. So this is the top image is a Goldman visual field that I did with an enlarged blind spot in both eyes. A 24-2 is inside this circle. So that's how much is missed when you do a 24-2 versus a Goldman. And you can see her 24-2s were densely depressed below, even though her visual acuity was pretty normal. On MRI, you can actually see, you can see the papilledema extruding into both eyes. I like to use the T2 axials for this because water is white on them. So the optic nerve really kind of, if it's really swollen, you can see through. It's not the most accurate thing, but it's something I look for. And she has flattening of her globes and dilation of her optic nerve sheaths. So she underwent a full workup and ended up having an opening pressure of 36. That was elevated. We did a rapid increase of her diamox because we were worried about her visual function and followed her very, very closely. Then over the course of 3 months, you can see her nerve went from extremely swollen to mildly swollen, or not swollen at all, but still a little bit of intraretinal fluid and exudates. From diagnosis, the optic nerve had volume to a month later. So that's from this picture to this picture. It went from over 11 to 5.28 and 5.65 in both eyes. And the ganglion cell layer started to thin over the course of a month. So she actually does have evidence of early optic atrophy. And she also, if you look, has evidence of IS-OS junction disruption in her retina, which is another thing that can cause vision loss in these patients. And patients who have retinal findings, I tend to be more aggressive in treating because I feel like time to decreasing that swelling is time for the photoreceptors to heal. Fast forward 2.5 years. She had one period of about 8 months after diagnosis where she self-discontinued her Diamox without recurrence of swelling. She now has optic atrophy. Her OCTs are 71 and 64. Her ganglion cell layers are 0.85 and 0.90, but stable. A year later, so now 3.5 years after diagnosis, she went to college and she gained around 20 pounds. She presented for her regularly scheduled follow-up and had been off Diamox for about a year. She noted that she had had some pulsatile tinnitus, but she hadn't thought about it for the first few months, and some mild headaches, but only after I really kind of pushed her. Her afferent visual function was still excellent. Here were her optic nerves. So they just look a little bit different than they had to me a year before. Her ganglion cell layer is still roughly the same at 0.88, 0.89. Her optic nerves, if you just look at the colors, 116 and 102, that looks pretty normal. Except that a year before, her optic nerves were in the 70s and 60s because she was atrophic. Her visual field was essentially normal, some nonspecific defects. We ended up treating her again with Diamox, and you see this is what her nerves actually should look like. And again, they're back in the 60s. And fortunately, she had no increase in the level of optic atrophy that she had, and has had no effect on her visual function. But here's another example of you don't trust the colors, and sometimes you can't even trust the numbers. You have to go with what the trend is. All right. Home stretch. So case 6A. So this was an 18-year-old girl with high myopia who presented for an evaluation of a visual field defect. It was initially noted after being seen by her optometrist and referred to a pediatric ophthalmologist, who then referred her to me. She was 20/20 in both eyes. She had full color vision, but she had a right afferent pupillary defect. MRI brain and orbits was negative for obvious compressive lesion at this point. Here was her visual field. So she has a right inferior altitudinal field defect. So again, going back to localization, it's obeying the horizontal meridian. So this points to an optic nerve problem. So now I'm thinking, okay, my OCT and fundus photo should help me because this is an optic nerve problem. And here's her picture. And you can see on the right that she has some segmental pallor of her supratemporal quadrant of her optic nerve. If you look at her OCT, she has generalized thinning, especially in the area that corresponds to the RNFL associated with that quadrant. And if you look at her ganglion cell, and I think this is the most interesting part, is it mirrors the visual field. So your superior macula tends to correspond with your inferior visual field. And so she's lost her right inferior visual field, and now she has thinning of that macula. So that's how it kind of looks, just like a visual field. And also the fact that she has RNFL thinning and GCL thinning kind of makes me realize that this has been going on for a really long time. And just to cut through so you can see there's no evidence of other interretinal issues. And so here's my next question. What is the next step in workup? Metabolic and vitamin labs to rule out a nutritional optic neuropathy, fluorescein angiography to evaluate for retinal artery occlusion, MRI brain to evaluate for compressive lesion. And I know it was already done, so I should have said, what is the first step in your workup? What should it be? Or an MRI brain and orbits and MRA to evaluate for sign of stroke. Awesome. So kind of mixed everywhere. So my answer, and I wouldn't know if I would call it the correct answer. So I think I'm going to combine the two MRI questions. I think they're both right, and the question was a little bit misleading. Is you have to do an MRI in her because you have to figure out, is there a compressive lesion? We already kind of ruled that out, but it's what you have to do first. Second, you have to evaluate for a sign of stroke because this looks like a non-arteritic ischemic optic neuropathy, which is super rare in children. And so I would pursue a significant workup in her. I don't think you need to do a fluorescein angiography to look for a sign of a retinal artery occlusion because I think your OCT tells you that there isn't a retinal artery occlusion. There's no interretinal thickening. And then in terms of metabolic and vitamin labs, it would be really atypical to have such an asymmetric optic neuropathy with a nutritional optic neuropathy. Usually it's bilateral. If it's genetic, it's usually bilateral and grossly symmetric, maybe slightly asymmetric, but grossly symmetric. So the fact that this is only in one eye and only kind of one altitudinal issue makes me kind of shy away from nutritional or even genetic optic neuropathies. You can think about Leber's hereditary optic neuropathy, but her central visual acuity is very good. So even though labors can be asymmetric, especially when it starts, and you can have a long gap, although it's usually about 6 weeks, you have a long gap between affecting both eyes. You would tend to see central visual acuity affected. And any of these nutritional or genetic optic neuropathies, same thing, central visual acuities would be affected and central scotomas would ensue. So it's not the right visual field defect and it's not a bilateral process. So we actually don't know what happened with her. Could it have been inflammatory optic neuritis? It's possible, although inflammatory optic neuritis doesn't usually respect the horizontal meridian like that does. A compressive lesion has been ruled out, so we went with the diagnosis of non-arteritic ischemic optic neuropathy, and she got a full stroke workup that was negative, and we've just been watching her since. The pearl here is if you can't date the onset of the optic neuropathy, you have to image. Case 6B. So this was a 13-year-old girl who was referred to the ED because of acute onset vision loss in the left eye. It happened around 24 hours prior. She noticed it, so different from the other case, and was seen at an outside ophthalmologist's office. Her right eye vision was normal. Her left eye visual acuity was 20/40, and she had decreased color vision to 2 out of 15. Here is her fundus photo. So this is what I was getting at before. If it's an artery occlusion, you're going to see it. You're going to see it on indirect ophthalmoscopy. You're going to see it on fundus photography. You're going to see it on optos. If you do that, you're going to see it on OCT imaging. So here you can see the raised whitening of the retina. She has a superior altitudinal field defect. And here it's an inferior branch retinal artery occlusion. And if you look at her OCT, you see this thickening of the inner retinal layers, and you can see it really well in the heat map. So this would tell you that now you do need to do a fluorescein angiography to make sure and see what's going on with perfusion and things like that, but it's not something you really need for diagnosis. You kind of have the diagnosis cinched already. And then several months later, you can see how that inner retina thins over time after it's been damaged like this. And so the important note here is artery occlusions require stroke workups because they are CNS strokes essentially. And we don't see them a ton in children. We see them more often in our sickle cell patients. Patients with lupus who have vasculitis can have them as well. So they don't happen often, but when they do happen, we need to know how to deal with them. Her stroke workup was negative, and she's been very stable since, and we don't really have an answer as to why it happened. So again, we go back to our map and kind of looking where the problems are. And we've been mostly focusing up front. I have 2 more cases. So this is a 13-year-old boy who presented to the emergency department with no significant past medical history, but had worsening headaches over the last couple of weeks and sudden vision changes. The headaches waxed and waned and were worse in the morning. His blurry vision was left greater than right. His right eye was 20/50, his left eye was 2400, and he had an afferent pupillary defect. He could only see the test plate in the right eye and could not even see the test plate in the left eye. This is my gross attempt at the visual fields I did because I was a fellow when I saw him and I was in the emergency department, didn't have a Humphrey visual field, but it looks like he has a significant visual field defect actually in both eyes. So my last question for you of the day. This type of visual field defect is known as a bitemporal hemianopia, junctional scotoma, homonymous hemianopia, and central scotoma. And the goal is to pick the one that is most descriptive. So if we look back at the image, there is a bitemporal hemianopia here, but there's a more descriptive term, and that is junctional scotoma, because what likely happened is the optic chiasm is being compressed. You have bitemporal visual field loss, but the optic nerve in his left eye is clearly affected because he's 2400. So the tumor is compressing the left optic nerve as well, which is called a junctional scotoma. A homonymous hemianopia is one from a lesion that we'll see in the next case where it's behind the chiasm and you see a left-sided defect or a right-sided defect in both eyes. So a junctional scotoma would be if the defect in the right eye was, a homonymous hemianopia would be if the defect was actually here and here versus the more bitemporal look here that you see. So he actually had normal OCT testing. And so we did imaging emergently, and he had a evidence of a pituitary lesion that had mixed density components, likely acute hemorrhage, which caused his worsening of his vision so quickly. He went for surgery almost right away, and his visual acuity was 20/20 in both eyes with full color vision after his surgery. Here was his visual field and his Goldmod visual field and his OCTs. So everything looked really, really good. And it was all because that we could tell it was going to come back because we had the OCTs from preoperatively. And so we actually looked at our cellular tumors and presented this at APOS and NANOS in the last 2 years. And basically what we found is that if your ganglion cell layer is over 1.01 prior to treatment and at diagnosis, it's very unlikely that you're going to have visual field loss or visual acuity loss. If your ganglion cell layer is over 0.75, it's very unlikely that you're going to have visual acuity loss, but you likely will have some visual field loss. And both RNFL and GCL were very well correlated with the visual field findings. GCL just thins faster, so it gives you a faster way to intervene if you notice a change. I think you'll notice a change more quickly on the GCL. So that was his final diagnosis. And the last case, this was a 12-year-old girl who presented for acute vision loss. She noticed that she could not see well out of the right side of her vision for the past 2 weeks. She has a history of congenital heart disease that was corrected in infancy. And an MRI revealed an old-appearing infarct in the left occipital lobes, but that extended into her left optic radiations. So now we're talking about back here. Unless the right side, so back here on the left side. And you see her Humphrey visual field. So this is a homonymous hemianopia. So it's a right homonymous hemianopia. So she sees temporally in the left eye and nasally in the right eye. And if we look at her OCT testing, she has thinning of her RNFLs, and you can see that she has thinning of the retina that's corresponding to those visual field defects. So she had an ischemic stroke involving the left optic radiation, and as a result had a homonymous hemianopia. And you can see the homonymous hemianopia on the GCL imaging. So nasal retina in the right eye corresponds to the right temporal visual field, and temporal retina in the left eye corresponds to the left nasal visual field, or a right homonymous hemianopia. And we could tell that it was chronic because her RNFL and GCL were both aggressively thinned. So this had been there at least several months, not the 2 weeks that she had noticed it, and it corresponded with the MRI. It likely happened when she had her heart surgery as an infant. So the goals of my talk. I hope that you'll be able to determine and interpret which OCT is most useful in each situation. Optic nerve head volume and EDI-OCT are very useful for PHOMS and optic nerve head drusen. They can be useful for papilledema if it's so much papilledema and you want to have a number to track. RNFL and GCL give you more function, so afferent visual function, and then some structure with the RNFL and papilledema. And then OCT macula, because sometimes there's subretinal fluid, sometimes there's a retinal artery occlusion. So you always have to be thinking beyond just what your specialty is. OCT can help us localize and date a lesion. It's kind of like a visual field. Is it a one-eye problem, optic nerve, before optic chiasm, or a two-eye problem behind the optic chiasm? The GCL starts to thin in 2 weeks. So if you start seeing GCL thinning but haven't seen RNFL thinning, it kind of gives you a timeline as to when things started. RNFL starts to thin at 3 to 6 months. The one caveat being if you have a direct traumatic optic neuropathy or some kind of acute insult, it will thin faster. We can use OCT to help us guide our management decisions. We can, for optic nerve head volume, smaller is generally better, unless it's very atrophic. For RNFL, thinner might be better, but if it's too thin, it's atrophic. And finally, GCL, thinning is definitely not better. And GCL, all you have to do is get a macula scan, and your machine will let you segment it to get the ganglion cell layer, and it's the fastest scan. So it's another take-home point. So thank you so much for having me and listening. So I'm going to go through the questions. With OCT optic nerves, all quadrants appear white in kids, as opposed to adult OCT. How can this help? And then a comment after, OCT is non-invasive technique used to visualize the optic nerve and retinal nerve fiber layer. Yes. So it can still help because I'm looking more at the global RNFL. So quadrants are a little bit less important to me. You can, they're white because there's no normative data. So the global RNFL can still help you. And in some machines, you can actually just use it to use the adult data, and it can tell you what an adult looks like versus a child. So even though they're white, if you use the global average RNFL number, that number should still be useful to you. So it's not exactly there, but I don't use the sections or segments or quadrants of the OCT nearly as much as I do that of the ganglion cell layer. And when you look at the ganglion cell layer, it gives you a disc, so you can actually see what quadrants are affected on the heat map, and it makes it much more helpful. PHOMS are not, so another question, are PHOMS hyper autofluorescent on fundus autofluorescent? And the answer is no. You can't see PHOMS on fundus autofluorescence. Can we do MRI on a single patient many times in a month? Is it safe for children? Yes, you can do MRIs many times in a month. There is no evidence that it is not, MRI itself is very safe. The question becomes is what happens with contrast when you do contrast many times in a month? It is theorized to deposit in the brain and stay there forever. It's more of a question for radiology than for me. But my thought process is you do as many MRIs as is needed to keep the child safe and alive and with good vision. The more MRIs that you need to do, if there's a reason you need to do them, then you can do them. There's no literature that states that contrast yet is not safe. We do a lot of non-contrasted studies on our patients. So like patients who have idiopathic intracranial hypertension workups, and we generally start with an MRI brain and MRV without contrast. So an MRI brain can look for a large mass lesion, and MRV can look for a venous sinus thrombosis, and all done without contrast. You can also do fast MRIs where you're looking for hydrocephalus and other things like that for neurosurgery that don't require contrast. So not all MRIs necessarily need contrast every time. EDI-OCT was prescribed in case 4. So hold on one second and let me pull up case 4 so I don't get it confused. Case 4 had severe idiopathic intracranial hypertension with an opening pressure of 36. So EDI-OCT was prescribed in order to lower the intracranial pressure. In children, the treatment of idiopathic intracranial hypertension is very similar to adults. The one caveat that I would always mention is that kids are much more sensitive to the acidosis. So we do check labs quite frequently, especially when starting and if they're symptomatic at all. And we will replete with bicarbonate, either prescription bicarbonate, or the easiest thing to do is baking soda is actually sodium bicarbonate. So if you take a quarter of a teaspoon of baking soda, I believe it's 14 MEQs of bicarbonate. So that's one of the ways that we will replete that. Next question. Does nevus in children should always be imaged by OCT? So that's a little more a question for my ocular oncology colleagues. I usually don't do OCTs regularly for nevuses. I usually watch the fundus photography and see if there are any concerning signs or symptoms, then would consider OCT after. Could you please repeat the relationship between the GCL thickness and visual acuity and visual field loss? Yes. So hopefully this will be published in an article soon. So in patients with cellar or supracellar tumors, I did go through this quite quickly, they have compression at the optic chiasm. What we noted is that if your ganglion cell layer was over 1.01 preoperatively, before the lesion was removed, you had a much lower chance of having any visual field or visual acuity loss. If your ganglion cell layer was down but was over 0.75, then you likely had visual field loss, but were unlikely to have visual acuity loss because visual acuity is the last thing to go. Based on the last case that you presented, do you advocate that all pediatric cardiac surgeries be accomplished by close pediatric ophthalmology follow-up and OCTs? I do not. I think that this was a rare occurrence of a silent insult that where the patient is neurodivergent and just didn't notice it for a long time because she thought it was normal, and it was until she was older that she could kind of talk about the lesion. We don't typically see all patients who undergo cardiac surgeries unless there's a known issue intraoperatively or postoperatively where there's a stroke or something like that, which does unfortunately happen, but not as standard of care that we should have pediatric ophthalmology follow-up, only if there are complaints. Is there a possibility to identify metastasis in the optic nerve involvement in retinoblastoma? It's hard because theoretically, a lot of these children with retinoblastoma are much younger and they can't really sit for OCT imaging, or the tumors are very large and they would obscure the OCT imaging. My colleague Efren Gonzalez, who's our ocular oncologist, I don't believe he uses it regularly for that use. Next question. So if a patient with IAH on treatment shows signs of reduced optic nerve head swelling and the OCT shows reduced RNFL thickness, if the MGCL macular GCL is also reduced, is this a sign of concern? Yes. So the GCL is the first marker and it will thin even if there is papilledema. Again, you have to be really careful if you use the Gise Cirrus machine because the ganglion cell complex that it segments is often thrown off by the papilledema and best segment correctly. But if I saw a patient with ganglion cell layer loss, it is always of concern, even in this case, because the other thing that can reduce optic nerve head swelling and RNFL volumes is atrophy. So if the nerve is dying, then it's not that you successfully treated the high pressure, it's that the high pressure won or is winning. And so I would say that would make me inclined to push further in treatment. Can aspirin be prescribed in ischemic retinitis cases? If yes, how effective is it? I'm not entirely sure what the question is implying. They do use aspirin for stroke prevention. Unfortunately, once you have an artery occlusion, if you're outside of the window, which most people tend to be because they present later, there's really not much more we can do. The neurology teams can treat them as strokes and do catheter guided TPA and things like that, but those have to be within a certain window. Sometimes it is difficult to assess if a disc has pallor related to optic neuropathy. Any tips on this? This is a great question. Absolutely. It depends on the color of the retina, the shade of the retina, depending on the skin color of the patient. It depends on, how their nerves look. Temporal pallor is one of my mentors never thought temporal pallor was worth the salt or anything. So it can be really hard. And so this is one of the ways that I think OCT is very helpful. I think fundus photography is helpful too, because it gives you a chance to really look at the nerve, but sometimes they're overexposed. And if you only have an Optos machine, the nerves look very different on Optos because of the color changes that the machine does. So I think this is where I would say that it's very helpful to have an OCT. Just yesterday in clinic, one of our fellows and I were looking at a patient where the nerve looked maybe a little temporal pallor to our eyes, but when we looked at the OCTs, they were totally normal. So I think that it is very helpful, and one of the reasons why I advocate for its use, and especially because it's so fast and non-invasive. Next question. Can you see the drusen border in OCT if the druse is not calcified? No, you generally don't see them like that. You can see there are some precursors, some hyperreflective lines. I highly recommend that everyone take a look at the paper that was put out by the Optic Disc Drusen Consortium in 2018 that this is all derived from, because they have great examples of it. So if it's not calcified, then you don't have that hyperreflectivity, but there can be some signs that something else is there, and they may be drusen precursors as long as you're not looking at PHOMS. The OCT parameters which you shared, are they applicable only for the spectralis, or can they be roughly applied to other machines also? We have a Topcon. This is a problem. They really can only be applied to the spectralis. The reason being is that all the OCT machines are different, and there are some published equations online where you can convert from one OCT machine to another. But in general, you're comparing apples and oranges. So I would be very hesitant to use any of my numbers not on a spectralis. It just happens to be what we use. There are a lot of different children normative data studies that have come out with different machines, though. So it's just not programmed into the machine as normative data. So I would recommend looking some of them up. Mays Eldary from Duke published a couple of them. Next question. For the elevated optic nerve, how do you tell from an OCT that it is edema versus non-calcified drusen, assuming the patient is asymptomatic and normal visual functions? That's a great question. You can't. You can think that there is a hint of drusen in how the nerve looks. It has that extra fluffy white appearance around it. You can try other imaging modalities to see if you can see signs of calcification that you couldn't see on the EDI-OCT or anything. But if it's truly non-calcified, then it becomes harder and you have to use your best guess. I tend to image patients when I really can't find drusen. If I have any concerns at all at how the nerve looks, if they have any other neurologic findings. I know you said the question was about asymptomatic patients and normal visual function. The other thing I'll often do is have them come back in a short interval follow-up of 2 or 3 months and just see if anything changes. And if I have stability, then I feel more comfortable watching them rather than doing anything and waiting for the drusen to calcify. I would say, though, that most of the time, if it's non-calcified drusen and I can't see them and it looks like edema, they will get more of a workup. Do you use RNFL thickness to evaluate the follow-up of PTC patients, so pseudotumor patients? Is it adequate to evaluate the response to treatment? So this is actually an area of disagreement between me and one of my colleagues, Dr. Eric Geyer, who's here at Children's. I do. I think that the RNFL will become less thick when you use Diamox and the swelling goes away. I think that studies have shown that. I think that it is very helpful in that. I think you can also look in and see if the swelling is better, like with fundus photos too. Cost again becomes an issue. So in the United States, you can't bill for both a fundus photo and an OCT. So, and one OCT is pretty much the same as any other OCT, and you can only bill for one. So I can do all the OCTs I want, all the fundus photos I want, and all the autofluorescence that I want, and all it does is cost time of mine and my staff. And so that's why I don't worry about it and why I get all the pictures I possibly can, because the more information, the better. But the simple answer to your question is, yes, I use RNFL thickness to evaluate for follow-up of pseudotumor patients. I do think it is adequate to evaluate response to treatment. I think that you combine it with the fundus photo too, so that you can make sure that you see improvement. Next question. Do you use ganglion cell thickness to make decisions for treatment in optic pathway glioma patients? Progressive thinning, but no changes in MRI and visual acuity. Oncologists don't. It's a group decision. So it depends on how thin the ganglion cell is. Rob Avery and his wonderful group has published on this about the use of ganglion cell layer in these patients, where they talk about, certain percentages of decline make you more concerned that there would be vision loss. I think some ganglion cell layer decline with no visual function changes can be observed. I think when it gets to a certain level, though, and they talks about these exact numbers in those studies, then you start to talk to the oncologist about saying, like, this is going to eventually affect his vision or her vision. And so we we tend to have a very team-friendly approach when dealing with these patients. I need further clarification on the RNFL thickness. What is the normal range in both adults and children's, and what group of retinal disorders does it signify? So I don't, in children, in RNFL, what we found on the spectralis, like I said, is around 100 is normal. I think in my practice, I consider up to 130 normal in some cases, but I find that once you get over 120, it starts to be a little bit of a gray area. And once we're in that gray area, then it's kind of, you can have a normal number and still have pathology, if that makes sense. In adults, I feel like the normative range is similar. It's like 90 to 100. I don't see adults in my practice anymore, thankfully. I'm very much pediatric focused. But it is similar. And then in terms of retinal disorders, does it signify? RNFL thickness is an optic nerve tool. So I tend to use it as such. I don't really use it for retinal disorders. I do have one patient who had toxicity from vigabatrin, and he's one of the very rare vigabatrin patients that can sit for an OCT, and has had thinning of his RNFL because of outer retinal or retinal damage, whereas ganglion cell layer remained normal and has no visual changes, but that was how we caught his vigabatrin toxicity. Next question. Are there clinical predictors that suggest a child with PHOMS may be at risk for progressive visual field loss? No, there aren't. In fact, what we found is PHOMS had no, in our study, looking at all those different pathologies, the presence or absence of PHOMS did not have any bearing on visual outcomes. So I don't think we have that answer entirely mapped out, but for right now, I would say the answer is no. And if I see a child with PHOMS, I don't automatically think, oh, they're going to have something wrong, or oh, there's going to be vision loss, or oh, it changes my management in any way. I usually try to explain why they have PHOMS. Like, do they have a very myopic nerve, a very tilted nerve? Is it a very crowded nerve? Do they have drusen? Do they have papilledema? But short of that, the PHOMS themselves would not be a clinical predictor. What additional information does EDI-OCT give on PHOMS or drusen? So for drusen, EDI-OCT can give you, if there's choroidal neovascularization, you can see subretinal fluid next to the optic nerve. I find it's very helpful for that. And in terms of PHOMS, it doesn't give much more information other than presence or absence. For drusen, you can also see the size of the drusen. If they, obviously, if you are having an optic neuropathy from drusen, which can happen, you can usually see larger drusen and there's much less room for the optic nerve. But that's pretty much the information that it gives. The big information is presence or absence, and then presence or absence of choroidal neovascularization if there's subretinal fluid. How long to be given Diamox? Next question was, how long should patients be treated with Diamox for IAH? That's a great question. If you have the answer, please let me know. I think it's incredibly individualistic. I generally, for IAH, will keep patients on Diamox for 9 months, 6 to 9 months after resolution of papilledema, and then I'll start tapering slowly by about a quarter of the dose every 3 months. If they have a very large body habitus and have not lost any weight, I'll tend to wait longer. It's very, my patient that I mentioned earlier, she went to college and gained weight and then ended up having a recurrence of her papilledema. So it's part of the art of medicine rather than the science, I feel. Next question. Sometimes we accidentally discover segmental, usually temporal opticus pallor in a completely normal child. Should I do an OCT and optic nerve and macula in those cases? Any need for a follow-up examination if normal? How long and what is the interval? Thanks. So if you think you see temporal pallor, I would do an OCT. I think that's a great reason to do an OCT. I would do an OCT of the optic nerve and I would do an OCT of the macula because I like to have both things. Usually temporal pallor is more a factor of how the eye looks than actual pathology. So if it was normal, I might consider a follow-up in a year if I was concerned. that would probably be what I would do, because my answer would be if there's pallor in the optic nerve, it takes months and months to set in, and if it's truly atrophy. And so you would see it on the RNFL or the ganglion cell layer, especially if there was true atrophy. But I think that it is a great way to make everyone feel better. And it's, again, so non-invasive, which is why I like it. How do you integrate OCT findings with visual field testing when children cannot reliably perform perimetry? That is a great question. So I would push back on you a little bit and say, you can't lump all children together. Some children are absolutely wonderful at doing perimetry, even if it's automated perimetry. They think of it like a video game, and I will be very honest that I think that my teenagers can perform visual fields better than any adult I ever tested in neuro-ophthalmology fellowship. In the younger children, they really can't reliably perform perimetry. Sometimes you can get them to do a Goldmont, although they don't make those anymore, and they're hard to get. Sometimes you can have them do a kinetic visual field on a Humphrey or an octopus, depending on their age. If they're very, very young and really unable, then you throw out the perimetry, and I use the OCT findings to guide my treatment and my thoughts. Because again, it's an objective measure. Perimetry is more of a subjective test. But OCT, it also is reproducible, like I talked about. So the answer is you use the, or I shouldn't say the answer. My answer is you use the OCT and you use a trend in the visual fields. If they're really terribly and unreliable, then you can't use them, and then you just go by the OCT. Next question. Have you ever observed asymptomatic optic disc edema in adolescents that resolved spontaneous, especially after chickenpox? No complaints of headaches or visual field defects, just mild swelling that went away on its own. Absolutely. So a couple of things. Chickenpox, no. We don't see a lot of it, though, with the vaccine. But you can get very mild viral meningitises where the kids are really sick for a couple of days, and by the time they show up, they have swelling. And I've worked them up, and their opening pressures are usually normal in the palp, and it goes away within a couple of weeks. You can also see it if they had a little bit of anterior chamber inflammation. So like COVID or Kawasaki's disease, you can get papillitis. That will go away. It is usually self-resolved once the general process is treated. So yes. Next question. Age 12-year-old premenarche girl has a melanotic and vascular anomaly of the optic disc border with a big blind spot. FA is not leaking. Can I perform OCT alone, or do I have to repeat an FA, and how often? It's a good question. I would probably start by doing OCT, because I think that if it does start to leak, you're going to see subretinal fluid there. I think I would probably perform an FA every couple of years at least. One of my colleagues, Nimesh Patel, who's a pediatric retina specialist, is really a big fan of oral FAs, because I know obviously injected FAs can be challenging in kids. There is literature out about how it is roughly effective depending on what you're looking for. And for late leakage especially, I think that oral FAs are great. So it might be a way to minimize some of the kind of trauma of having to do injections over and over again. But I think that EDI-OCT would be a great way to monitor that. Why is the case of the chiasm mass you stated a junctional scotoma? So it is a junctional scotoma means that one eye has central scotoma and the other eye has a supratemporal field defect because it's the junction of the optic nerve and the chiasm. Yes and no. I was taught that a junctional scotoma means that you have a bitemporal hemianopia, but you also have spillover where the optic nerve is affected right at that junction. So he had a very large central scotoma, and that's why he had such decreased vision. That's why I would call it a junctional scotoma. Next question. How should a child presenting with a sudden arterial occlusion be managed in the emergency department? That's a simple answer. Call a code stroke, and it should be dealt with by the stroke neurology team. Next question. How do you feel as a neuro-ophthalmologist when investigations keep turning out negative, yet you have an obvious pathology before you? That's a great question. Helpless. Um, the I saw a patient yesterday who has an intranuclear ophthalmoplegia and has no evidence of what caused it, but it's very clear as day on the exam, and he's had an extensive workup for it. I It's one of those things where I think that you end up thinking to yourself and just watching and doing the best you can, and hope that the answer comes up as time goes on. And my best example for that is that 15 years ago we were talking about MOG, a myelin oligodendrocyte related disease, as a kind of experimental test, and it was very expensive to get. And now it's fairly commercial and mainstream, and a very well known cause of optic neuritis in children. Just because we don't have the answer yet doesn't mean we're not going to have the answers soon. And I also try to ask the smartest people I know. I tell all our trainees that the most important thing that you can have as a physician is the ability to know when to ask for help and when you're in over your head. And you try to find the smartest person in the room. So I hope that helps. When is the youngest age you can do an OCT optimally? Around 3. I've had a couple of really good 3-year-olds do OCTs. Otherwise, it can be anywhere from 3 to 5. What is your approach to OCT testing in a child with nystagmus? For example, ocular albinism, how do you ensure accuracy? So when you have nystagmus, getting an OCT is extremely difficult. Usually you can't get much. If a child has nystagmus, you're really interested in the fovea, especially for ocular albinism. So my answer is to try to get a sweep, which is the lowest sensitivity test you can get, or at least one kind of image right through the center of the macula, because that's going to look at your fovea and see if you have foveal hypoplasia. I'll also try to get a fundus photo, because I think that sometimes it's a lot easier to see foveal hypoplasia on a fundus photo than in a child who is quite squirmy. In pediatric cases, how often are we aware of retinal problems? It varied. It's a very broad question. I'm not sure I have an exact answer for you. I think that over time you kind of discover, you kind of look and you make sure it's not an optic nerve problem, and then when you figure out that it's not an optic nerve problem, you then move on to the retina. I think that retina and neuro-ophthalmology tend to be kind of the places of last resort. So both fields tend to get a little bit more familiar with each other. What is the value of autofluorescence on the FFA camera without injecting fluorescein for optic drusen diagnosis? So that's a great question too. Autofluorescence does not require fluorescein. Autofluorescence is something that's done, and certain tissues will hyperfluoresce. Calcified drusen is one of them. So drusen will hyperfluoresce even without an injection of fluorescein. Thank you for everything. Thank you for CyberSight for being here. And special thanks to Andy Chen, who was extremely helpful in all of this.